Okay.
All right. Hi, everyone. I know you all are starting to trickle in. So we are so happy to hear you have you here. While everyone's coming in, it would be great if in the chat box you can drop your fertility faux pas. So what is something that is said to you while you're on your infertility journey that just really bugs the crap out of you? Let's be real here. Just go ahead and drop it in. That would be great for us to just see as we're chatting about our topic today.
I have many, but I'm gonna maybe I'll do them later. Oh, I've heard it all.
I think it's really interesting to see how many things people feel like it's appropriate to say when someone's on such an emotional journey.
Yeah, I agree. It's, and I always tell this to my patients and to everyone who would listen, is that, this, we know, like, this is not just me thinking about it or us saying it. Some of my colleagues have performed studies using validated surveys assessing stress and anxiety, depression of young individuals facing infertility, and it really does match those of people who are diagnosed with cancer. Mm-hmm. So it's a real thing, and I think that one of the most common reasons for actually not having a baby at the end of all the fertility treatments is not because of the limitations of the treatment, but rather it's because of emotional exhaustion and just dropping out of treatment because it's too much. So it's a real thing.
Yeah, exactly. I think we don't give that enough credit as to how much your emotional wellness and emotional health really plays a role in your overall well-being.
Yeah. Not because it causes the problems. I don't think that, and right. I know that that's not what you're saying, but I think that's one of the big faux pas. It's like, well, just relax. My friend did this and they got pregnant. Like, no, it doesn't work that way. It's not that you are, stressed. That's not the reason why you're not getting pregnant. But, you're not getting pregnant, and that's why you're stressed. And that causes emotional, trauma and other problems. And if long-standing, it really can cause PTSD, and maybe it's a topic for a different discussion, but it's a real thing. And I think that anyone going through the journey of this kind of, of this sort should really should get help and somebody that can support them and guide them through it emotionally and mentally, because it's extremely important, I think.
Yeah, absolutely. Well, you know what? Thanks so much for that, Dr. Lekovich. Let's just get started, because I think the topic today is so interesting, and I know we're going to have a lot of questions after. But guys, feel free to drop your comments, your fertility faux pas in the chat box. We'd love to just kind of look at those and peruse them as the talk goes on. But thank you so much for joining us today. We are hosting our next installment of our speaker series, and today it's all about fertility preservation. Before we dive into the topic at hand, I want to quickly introduce myself. My name is Amy Devrania, and I'm the CEO and founder of Oova. I went through a really tough journey when I was trying to conceive, and I founded Oova as a result of it. Oova is an at-home fertility diagnostic that monitors two hormones, luteinizing hormone and progesterone, through your urine. We quantitatively measure these hormones to determine your most fertile days and confirm if you actually ovulated. Our test is completely personalized, so we don't wait for your hormones to reach some arbitrary threshold. We capture your baseline levels and then detect fluctuations by comparing to that. You simply pee on an Oova strip, scan it with your phone, and then get your results in seconds. In addition, you don't have to mail anything to a lab, samples or results. We actually do all the interpretation for you. So we provide you with lab quality results in the privacy of your own home within minutes. And if you're interested in more information, check out our website at oova.life. And for our guest today, we are offering a 15% discount using the code PRESERVEYOURFERTILITY. And the code is valid until the end of the month, so Halloween. Just some quick housekeeping points. We're going to have a short presentation by our guest speaker, followed by a Q&A. And if you have any questions during the talk, please feel free to drop them in the chat box. Today, we're going to be doing a really deep dive into everything related to fertility preservation. And I'm thrilled to have Dr. Jovana Lekovich from RMA of New York join us tonight. Dr. Lekovich is a double board certified OBGYN and reproductive endocrinologist and infertility specialist at RMA of New York. She is the director of Oncofertility Program at Blavatnik, sorry if I'm saying that wrong, Family Chelsea Medical Center at Mount Sinai. Dr. Lekovich is an assistant clinical professor at the Icahn School of Medicine at Mount Sinai in New York. She specializes in treating all aspects of reproductive medicine and infertility, including conditions such as amenorrhea, polycystic ovarian syndrome, and diminished ovarian reserve with ovulation induction, IUI, IVF, ICSI, and pre-implantation genetic testing of embryos. She also uses minimally invasive techniques such as laparoscopy and hysteroscopy to treat a variety of surgical conditions, including endometriosis and uterine factor infertility. Dr. Lekovich, thank you so much for joining us today, and I will hand it over to you.
Hi, Amy. Thank you so much for inviting me and for organizing really this get together during which we can talk and raise awareness about fertility preservation, which I think is becoming an extremely important thing for every woman to know, because it does tie into, ties into our fertility, understanding how our fertility works. And then with the socioeconomic changes that the world is going through, and with advent of medicine and economy, there are some drastic paradigm shifts that we have been observing in the recent years or recent decades that I think we should be following and understanding so that we can have the best outcome for ourselves and for the world in general. So thank you for having me, and thank you for everything that you do.
Thank you.
Tell me, do you want me to just start talking about the topic, or I think that's,
yeah, I think
this
so.
is, okay.
This
is what
informal, but go ahead and just
Sure.
give an overview, and then we can start diving into some questions.
I think that this is something that I talk about at least 4 to 5 times a day. So in my own head, I sound like a broken record, but I really do. You will leave this this seminar and this get together knowing everything, pretty much everything about fertility preservation and your own fertility is what I do, what I know. So I really like to educate, and I really like to use platforms such as this one to really to just break some barriers and break some myths and just really break it down. I might use some weird metaphors, but I think it's all in good faith, and it's just so that we make it a little bit easier for everybody to understand. So fertility preservation, we were just chatting about this before we started, is the process through which people will go through in order to preserve their gametes. People with ovaries, then it will be preserving their oocytes. People with testicles will be preserving their spermatozoa or sperm. And it was classically divided into 2 major types. One would be preserving your fertility electively, meaning without major medical reason, just because you wish to delay childbearing for any non-medical reason. And then there will be medically indicated fertility preservation for many groups of people who are doing so because there's something on the horizon that has a potential to diminish their future fertility. And so classically, obviously, one of the typical situations would be being diagnosed with a cancer, either cancer of the reproductive organs, surgery of which or removal of which could lead to surgical loss of those precious tissues and later on infertility, but also being diagnosed with cancer of other organs in your body, treatment of which would require chemotherapy or radiation. We know these are some of the most important factors that can abruptly destroy those precious tissues and lead to abrupt loss of either oocytes or spermatozoa or health of other fertility organs such as pituitary gland or the uterus and fallopian tubes and so forth. There are many benign conditions such as fibroids, adenomyosis, endometriosis, big cysts, or recurring benign tumors of the ovary that would require multiple removal or recurrent removal of these structures from the fertility organs, which can then lead to their loss little by little. There are a group of people who are obviously would not diagnose it as a medical condition, but rather, people who wish to go through certain treatment to transition or to go through gender affirming either surgical treatment or hormonal treatment. We know that specifically surgical treatment when an individual is on their way to go through to transition into the desired gender can lead to irreversible loss of fertility. So there are many, many different categories where a medical condition or a situation in which you're in warrants considering preserving fertility before you would undergo that kind of treatment, surgery, radiation, and so forth. However, in the recent years, what we once called elective fertility preservation, which really referred to freezing fertility for sort of in a situation in which there is no medical condition that is lingering and can cause abrupt loss of fertility function, with some changes that we're going through as a society, not just us, but globally. Our bodies are created to be at the peak of their fertility between the ages of 14 and let's say 21 or 22. And, our fertility really is at peak during those years and kind of starts to decline towards the end of 20s. We never even knew about this, 1 or 2 centuries ago, because you would, start becoming reproductively competent by going through puberty and maturation, start popping babies right after your bat mitzvah or whatever was that, the coming out of age ritual, and would not even know about what menopause is because you would die from, plague at 26 or from influenza in your 30s. And so through the history, a lot of, people or a lot of societies did not really even know about the actual reproductive lifespan of humans because we never really lived that long, or people would be done childbearing much earlier than it will be realized what our reproductive potential is. In the recent decades, specifically in the past decade or past 2 decades, I would say, we have witnessed this amazing increase in lifespan and human lifespan for both, men and women globally, but specifically in the United States. If you are a woman living in the United States and you make it to 65, you have about 75% chances of living to 87. So these are just some simple statistics. Obviously, all of this came to be because of improvement in our prevention, in our nutrition, in the lifestyles, economy, lack of, wars that we used to have. And, obviously a lot of people used to die in wars, but the socioeconomic changes that the society has been through in the recent decades has led to this significant improvement in the human lifespan. And so normally the next thing that happens is for the reproductive lifespan to follow that prolongation of a lifespan. And really, if you're going to live to 87, there's really nothing wrong, and there's no reason to not have kids in your 40s if you're still going to be there for another 47 years to be with them. You actually, if you have kids in your 40s nowadays, you have a better chance of being there around and spending longer time with them than if you were a mom 200 years ago who would have a baby at 16. because of that prolongation of lifespan. The problem is that the ovary did not really get the message. And so while we found a way to, through the advent of, as we said, economy and society as a whole, and medicine and nutrition and all of these things, we found a way to prolong the functioning of other organs, such as, and to delay age-related diseases, or their onset rather, such as cancer and diabetes and cardiovascular disease and so forth. Ovary we still haven't made any strides in prolonging the function of the ovary. And it really comes down to how the ovary is created during embryonic life. And so I like to explain that a little bit so that you understand how your fertility functions, and therefore how this ties into the whole concept of fertility preservation, and ultimately how we go through the process of preserving your fertility. So the biggest difference between the ovary and the testicle is that the testicles are formed in such a way that they contain stem cells after the individual is born. And so for people with testicles, their stem cells that are contained within the testicles, they start to be active once the person hits puberty, and they start to differentiate into spermatozoa roughly every 2 months or so. So people with testicles do produce sperm cells every 2 months until they die. And there's no stopping that process. Obviously, the quality of those cells is declining with age, their motility, their DNA is acquiring a lot of damages and so forth, but they do get to be regenerated, so to speak, until that individual dies. The ovary is created quite differently. And so even though people with ovaries do contain stem cells during fetal life, all of those stem cells have to be, we call them oogonia, they have to be differentiated into the final or finite cells that are called oocytes or eggs. And by the time we're born, there's roughly about 1 million or 2 of these eggs within the ovary. So what makes these eggs last for, let's say, 5 decades, five and a half decades, until the ovary goes into this physiologic insufficiency, which we call menopause, which is the time when we basically run out of eggs. And that median age of that in our country and across the world is about 51 and a half, is how the ovary is organized. So for a cell to be able to last and be potentially functional for that period of time without being regenerated, it has to be preserved within your body in a certain way. So this is exactly how the ovary is created during fetal life. Each oocyte at birth needs to be contained within a structure called a follicle, which is the functional unit of the ovary. And it basically comprises the oocyte with some surrounding ovarian cells that we call granulosa cells or follicular cells, and the whole structure called a follicle. As we said, about 1 million of them at birth. They're all microscopic. And so all these cells that are surrounding each egg are keeping the egg, they're producing certain factors that are basically keeping the egg within the state of no metabolic activity, okay? And so by the time we hit puberty, we have already lost about 3/4 of that. So once we hit puberty, we have about 3/4 of 1 million or 250,000 eggs left. They're all, again, contained within the follicles. And this is where my funny, but useful in my way, and in my opinion and the opinion of my patients, useful comparison comes, especially for those who are not in the field of medicine, to understand how basically your body sparingly uses these until it's time to run out of eggs. Is that, once we hit puberty, as we said, 12, 13, 11 to 13, or 10 to 14, or whatever, at that point, by that point, we have about 250,000 eggs left in the ovaries. And it's sort of like, imagine you're a trust fund kid and you've been given, you've been endowed with $250,000 by the age of 12, okay? Nobody's gonna just give you that money right away. They're gonna put it in the bank and they're gonna let you use little by little until you spend it all. And so now imagine you're 13, you have $250,000 in the bank, and every month the bank dispenses $20 to you, but you can only use $1. So that's what our ovaries do, right? From 250,000 eggs that we have in our ovaries that are all inactive, they're in the bank, they're suppressed. Every month, a little cohort proportional to what we have within that sleepy, pool, maybe about 20 follicles, they start developing rapidly. They leave that state of, no metabolic activity. They develop so that within a few weeks, by the time, we reach the first or second day of our period, there's going to be about 20 follicles that have developed from the microscopic state to a structure that we can see. This is where I'm going to share the screen just because I want to make it more graphic so that you can understand. You're still going to be able to see me here in the corner. Let me just blow this up. So basically, this is what those follicles look like. So imagine that you're now 30 years old. There's about 50,000 eggs left in your entire ovary, and 49,990 are embedded here. They're microscopic, teeny tiny ones. We can't see them, we can't hear them. But last month, a cohort of maybe 10 or 20 started developing from that pool and has developed two structures that we call antral follicles. Those are the $20 that your bank gave you. And they now measure about 4 to 5 millimeters in diameter, and they are the ones producing hormones such as AMH and other hormones. We can actually measure the size of this pool by doing an ultrasound. We literally count them. I count them with my patients, like, okay, we have 5 on this side and 6 on this side, together it's 11 or whatever. You can see them now with, with an ultrasound or with your naked eye. And there's another hormone that we use to assess the size of this pool, which should be proportional to the number of follicles that we see, which is called AMH, or anti-Mullerian hormone. So those are the $20 that your bank gave you. Now, this process is way more wasteful than that, because now from all of these, let's say 10 or 20 follicles we have in that pool that is developed from the microscopic pool, our pituitary gland, which is a little gland in between our eyes and the brain, kind of hanging off of the brain, is producing 2 hormones. One is called FSH, or follicle stimulating hormone. The other one is called LH, or luteinizing hormone. And the pituitary gland does so in just the right concentration to then select one of these guys to be the so-called dominant follicle. So that one gets selected early on in a cycle, by cycle day 4 or 5, and that one starts growing bigger and faster than the other ones. And by, let's say 14, 15th day of your menstrual cycle, where day 1 is the first day of the period, that one will sort of mature the egg within and rupture and release the egg, and that's what ovulation is. You have sex around that time. Hopefully sperm gets through the cervix, uterus, fallopian tube, meets that egg, fertilizes it, the embryo forms, you get pregnant. If you don't have sex around that time, that one egg disintegrates, or if you do, but the sperm doesn't find it for some reason, that one egg will disintegrate. All the other 9 of these guys that were selected from that cohort to grow together in that cohort will just die that month. And so will another maybe 100 or 200 from the microscopic pool. So we go into the next menstrual cycle, we now have 49,000 and maybe 780 follicles in the microscopic pool. Another cohort of 10 follicles will develop, 1 will grow and give us the egg, 9 will die. Now, if you're in a birth control pill, people always ask me, well, does this stop the process? No, it just means that you're not selecting that one. So basically your bank will give you $10, but you will not be able to even use that $1 that you otherwise can use if you're ovulating. So we're very inefficient as species. That's how I like to understand this, because this is, for instance, what separates monofollicular species from polyfollicular species. That's why, let's say cats, they have litters, because they would use a bigger proportion of this cohort in comparison to humans, or let's say other monofollicular species would be sheep or cows, or primates, elephants. We usually just ovulate 1. Some women ovulate 2 eggs a month, but that's rare. Typically 1 egg, 1 baby, and that's it. So what we basically try to do when we go through the process of controlled ovarian stimulation for purposes of gaining access to the eggs, for purposes of freezing them as form of fertility preservation, or for purposes of using them to make embryos when we are treating infertility, or when we do IVF for any other reason, is the same process. And it's basically it relies on this principle that I just explained. So instead of you getting those $10 from the bank, but you can only use one, now you can use all 10. And that's what controlled ovarian stimulation is. So by patients self-administering administering slightly higher doses of recombinant pituitary hormones, those same two hormones that we just mentioned, FSH and LH, we try to change the ratio of utilization of the follicles at the level of this cohort. Instead of having one growing and maturing the egg and 9 dying, we want to have maybe 8 or 9 growing and maturing the egg and only 1 or 2 dying that month. So that's what those shots are for. That's what you do when you go through the process. You might have read about this or heard from friends or somebody that you know. Those hormones are typically given twice a day. One is given in the morning, one in the evening. They're recombinant hormones of the pituitary gland. They're given in form of subcutaneous injections. Those are small needles or small injections that just go into the skin. Usually we use the skin of the belly. Some examples of such injections would be, let's say an EpiPen, a kid who needs an EpiPen because they have allergies that could be deadly, or insulin. For insulin-dependent diabetics, they also need to use subcutaneous injections, only they have to do this 8 to 10 times a day throughout their entire lives. But I hope this makes sense, like how we basically just, what we do. We cannot tap into those thousands upon thousands of teeny tiny microscopic eggs because they don't have receptors, they're not active. If we could, that would be the money, because you just get in there, you get a few thousand, you put them in the bank, that's it, but you can't do that. So basically, the process typically starts on the 2nd or 3rd day of your menstrual cycle, with exceptions to that rule, which we can talk about later. But let's say for purposes of this talk, we start stimulating by day 2 of your period cycle, before your brain has made a selection of that dominant one. And usually the whole process takes about 7 to 10 days. Of stimulation. Within those 7 to 10 days, you're going to be the best buddies with your doctor and with their team, because we probably come in about 4 to 6 times in for, repeated ultrasounds and blood work. We don't do this to torture people. We do it to assure 2 things. One is to make sure that we're recruiting a good proportion of these follicles. If the cohort size is 10 follicles, we don't want just 3 to be growing, 7 to be dying. That's not a good ratio. We need to adjust the dose of the hormones, potentially give more hormones to try to recruit more. We go for 80-90% of the cohort. And we're also measuring the size of the follicles, because as they're growing, we want to see and we want to catch them when the leading ones would reach about 18 to 19 millimeters in diameter, based on very early studies in early days of IVF, some 40 years ago. We know that that's sort of a sweet spot when the procedure for egg retrieval should be scheduled, to ensure the health and the majority of the eggs that you retrieve. So this is how the procedure is done. It looks horribly painful and invasive and horrible, but it's actually one of the probably least invasive and risky procedures that we perform in the field of reproductive medicine. Or in surgery in general. It's probably, in terms of its invasiveness, it's probably the most similar to a biopsy of some sort. Procedure is not painful because it's performed under sedation, so the patient's comfortably asleep. Procedure itself, even though my anesthesiologists like to correct me about this all the time, the actual operative time is rarely longer than 3-4 minutes. Patient is positioned as a patient would be positioned for, let's say, a pap smear or a gynecologic exam. So you're basically, we call this dorsal lithotomy position. Once the patient is comfortably asleep, we perform vaginal ultrasound, just like we do in the office. The difference between the ultrasound that we use in the operating room, and the one that we use in the office, is that this one has a little tunnel on its surface, and through that tunnel we introduce a very slim needle that goes through the sidewall of the vagina into each follicle. And so the needle is connected to the sterile closed suction system. So once you introduce the needle into the follicle, we basically activate the suction system, and we collect the fluid and the egg floating in that fluid into vials. Sorry, you have to apologize for, I really need to update this because my graphic skills are horrible, but I think you get the idea how this works. So we would basically retrieve follicles on one side, and once we're done with that side, then we go to the other side, we retrieve follicles on the other side. This needle that is used to retrieve the follicles is only slightly, but it's pretty much the same as a needle that is used to draw blood. It's just a little longer, so it can traverse the length of the vagina, but it's very, very, it's really slim. And so once the follicles are retrieved, we collect them into little vials. As we're doing the procedure, we have to be constantly, my surgical tech is giving these vials to the embryologist. And in fact, the operating room is located in the heart of the embryology lab, because we need to give them to the embryologist as soon as they're out of your body. Patients go to recovery room. Usually patients wake up 5-10 minutes later. You go home after 30-40 minutes. Generally speaking, discomfort after the procedure is usually like 75% of people don't report painful sensation, but rather bloating and pressure, feeling like you're gassy or like you had a huge meal, and you might be a little drowsy or sleepy from anesthesia. 1/4 of patients reports pain that, or like really like cramping type of situation. We never prescribe anything for pain, nothing more than just over-the-counter Motrin or Tylenol should be required. There's several risks associated, which are all exceedingly rare. The most commonly quoted risk, if you look at the big data and the studies, is a risk of bleeding. That would require observation in the emergency room, or even less commonly a blood transfusion or surgery, or I don't think I've ever seen that in my entire career, but needing a surgery. But once every, I would say 3,000 to 7,000 cases, there might be bleeding that is relevant that needs to be observed. Once in every 5,000 to 10,000 cases, there might be a need for a blood transfusion. You will know how many eggs are retrieved that morning before you leave. And about 2 hours later, the eggs are frozen. And should you come back to use them, this is what the egg looks like before we freeze it. It's this big, huge cell surrounded by those supporting cells of the follicle. It's the biggest cell in the human body. And the smallest cell in the human body is, yes, you've guessed that, it's the sperm cell. So we freeze these eggs. Once we thaw the eggs, should you come back to use them, even though the egg doesn't get damaged with the process of freezing and thawing, there's one layer that surrounds the egg. It's made out of sugar, and it's called Zona Pellucida. And basically the purpose of that layer during natural fertilization, when it's happening in your body, is to prevent a phenomenon of polyspermy, or to prevent multiple sperm cells from entering the egg. This sperm here doesn't know what this sperm here is doing, because there's like about 100,000 of them attacking the egg. And so the way that this works is, the second the first sperm cell would break through this layer during natural fertilization, it turns into stone and prevents other sperm cells from getting in, because that condition would not be compatible with life. You would have too many chromosomes. So this layer gets hardened with the process of freezing. And so sperm has a little bit of difficulty penetrating it naturally if the egg has been previously frozen. So we resort to assisted reproductive technology called ICSI, or Intra Cytoplasmic Sperm Injection, which is a fancy word for just really a microscopic needle that is used to inject the sperm cell to basically traverse that layer that is harder, that sperm now has difficulty penetrating because the egg has been frozen previously, and we just inject the sperm into the egg. This technology has been used since 1991, when the first live birth has been described in humans. And this is, within the past 30 years, it gained so much utility that it really represents about 80-90% of all the embryos created in the lab, whether the eggs have been frozen or, not frozen or fresh. This is basically what we use in 90% of the cases when we make embryos, not just our lab, but pretty much across the world, United States, Australia, Western Europe. This is what we use to make embryos in the lab, as opposed to the older method, which is called insemination, where you would just put the egg and 100,000 sperm cells into a dish, let them do their thing, you check it the next day, see how many embryos you got. The embryo is then developing for the next 5 or 6 days. And once it reaches a certain stage called the blastocyst, then we can transfer it or test it or freeze it again. Obviously, that depends on your situation. So this is really just a summary of the process. There are different calculators that we use in order to assess how many oocytes you would need according to the age at which you're freezing them, not at the age at which you're using them or thawing them, but at the age at which you're freezing them. Because the egg quality is declining, or the egg's ability to create healthy embryo, genetically normal embryo, is declining as we're getting older, which is the culprit, the hallmark of declining fertility in females or in women born with ovaries. The older we are, the more eggs we need to freeze to assure the same probability of at least one live birth. So I'm a huge supporter of the process because, again, I don't believe that we need to tap into creating families in our teenage years. We have moved a long way. We live longer, we live healthier, which led to prolongation of certain phases of our life, if you will. We have this prolonged adolescence that most people who are lucky enough to, live in developed world will go through. And so we use our teenage years and our 20s for education, for just having fun, for traveling, and not for having babies. But this is one thing that you can do for yourself so that you're not facing age-related infertility down the road. And obviously, this is something we highly recommend if there is a known condition or treatment standing in your way that we know will destroy everything. So I'm going to stop sharing here. Sorry, I know this was a lot to go through in about 20, 30 minutes, but this is how it is. I know it's a little complicated, but hopefully I think it, kind of made sense what I said. So I'll take some questions. Or Amy, do you think that, was there something that wasn't clear or that I should go over? Or...
I think this is wonderful. Thank you for that overview. I think, honestly, a lot of the analogies that you provided, I know you gave us a disclaimer early on, but it really helped paint a picture of what the reality is. And
right.
It's kind of like you are playing the lottery a little bit to see if you can conceive, which is a scary thought. But it kind of is that.
It's weird. It's weird. And, there's so much data coming out just in the recent several months, really showing that specifically women in medicine and specifically women in medical training, physicians, PAs, nurses, do tend to have a much higher rate of infertility. And it's even there when you compare it to age-matched controls who are not going through the treatment, because you would say, well, okay, they have to go through medical school, which is forever, and then residency, and then fellowship, and then you're building your practice. But even when you compare it to other professions where you see similar, delay in childbearing, women in medicine do tend to have a significantly higher risk of infertility and significantly higher risk of adverse pregnancy outcomes, higher risk of ectopic pregnancies, miscarriages. So there's a very special a place in my heart, obviously, for my colleagues, and we're trying to raise awareness specifically for them because many women still don't know. But honestly, for all of us, no matter what your situation is, interestingly, this data was looked at by one of my colleagues and friends at UCSF. For all this time, people think, well, it's women want to delay childbearing. That's why that's the most common reason to freeze your eggs, but it's not even. It's the lack of a partner. That's the number one reason when they surveyed thousands of women across the country freezing their eggs or considering to preserve their fertility. It wasn't because they were delaying childbearing for purposes of, career advancement or education. It was because of a lack of a partner.
I think it makes sense, right? I mean, it is pretty connected across the board. And,
Yeah.
There's just so much variety as to why people go through what they do. We did get an interesting question, and I get this a lot too, but how old is too old for fertility preservation? Oh, before you answer that, Dr. Lekovich, if you guys have any questions, I got a few during registration that we'll definitely ask, but if you have any other questions from the talk, please drop them in the chat or feel free to unmute and ask as well.
No, of course. Yeah, no, thank you for letting our participants know that, and they should. And obviously we should share our contact information. So if anybody remembers any important questions later on, feel free to reach out to us through Instagram or through our emails. Or I think that it really depends on the clinical context. I have patients who are, facing cancer, and, when we talk about fertility preservation for purposes of not an immediate medical condition that we know is going to destroy it all or has a potential, then we always say that like fertility preservation should be used, really, it should be your plan B, should not be your plan A, because nothing supersedes having kids earlier. And having eggs frozen is not 100% policy. It's not an insurance that you will have children. And I'll give some examples. But I think that, I have patients who were diagnosed with cancer and they're even like early 40s, mid 40s. And for them, for instance, this is really that's his plan A, because there's no plan B. I mean, there's always plan B, but that's oocyte donation. So I think it depends on the clinical context. I think that, from data from European studies in which it's even in couples who are facing infertility, you cannot really freeze embryos, you have to freeze eggs. We know that there's a significant advantage to using fresh eggs to make embryos than to use previously frozen eggs to make embryos starting at 36, and then significantly more or better chance of actually having, getting pregnant if you use fresh eggs to make embryos as opposed to previously frozen eggs to make embryos. So if I'm seeing patients who are, considering fertility preservation for purposes of, because of a lack of a partner or not medical condition, I have this conversation with them. I think that if you're in your late 30s, early 40s, you really should consider donor sperm and just freezing embryos, because it just gives you a better chance of freezing eggs.
The other question we got was, how does hypothalamic amenorrhea affect fertility? No, it's not specific to this, but it's an interesting question.
I think it's a very interesting question. I think that hypothalamic amenorrhea, you said, right?
Yep.
Yeah. Well, hypothalamic amenorrhea is just a very specific type of hypogonadotrophic hypogonadism in which ovary is not functioning, not because there's something wrong with the ovary, but because pituitary gland is suppressed. And hypothalamic amenorrhea represents one of the types of hypo that we call. And so it's an interesting condition because sometimes, you remember how we said, like, you have this money in a bank, and then you proportionally to that money that you have, you get, money to, that you can use every month. So let's say if we have 200,000 eggs frozen, a size of the follicular pool that develops every month should be about, let's say, 20. And if you have 100,000 frozen, then it might be 10. I'm simplifying this for purposes of making it more clear. But what we sometimes see with hypothalamic amenorrhea is that that number that develops every month might be disproportionately low to what we have in the microscopic pool. And what we often see in people with hypothalamic amenorrhea is that their parameters of ovarian reserve, because of that deep suppression, might actually be falsely lowered. And they might appear to have a lower ovarian reserve than they really do. We could never calculate the size of that pool short of doing a biopsy and counting the number of follicles. So we use those surrogate measures, which is the size of the developing cohort and the AMH. But sometimes, you know, those are not proportional, especially in women with hypothalamic amenorrhea. So how does that affect fertility preservation? The same way that it affects any other controlled ovarian stimulation. I think that women with HA often will benefit from protocols that are heavy in LH activity. So we tend to change the ratio between the FSH and LH activity in favor of LH activity. That's just like something, because that's what they need. And oftentimes they show up with AMH of 0.1 and 3 follicles, and they see a little bit of LH, which they never see. And you end up getting 40 eggs retrieved. It's not uncommon.
Does male partner sperm age matter when fertilizing frozen eggs?
It does. And this brings me to this, again, another plastic example of how egg freezing is not everything, because age-related infertility is not everything, right? You can have infertility for other reasons. And so that's why I say, like, egg freezing is not gonna, it doesn't mean you have a baby in your arms. It just means that if you are facing age-related infertility down the road and there are no additional factors, this can be extremely helpful. But let's take into consideration you froze 20 eggs when you were 27 and you met a great guy in your mid-30s and you had a first baby, and now you guys are in your late 30s or early 40s, and you want to have your second baby, things are not working out. You resort to your eggs, but he has no sperm. He develops a condition where something happens and there are no sperm cells left. You can have millions of eggs frozen unless you use donor sperm, or unless he has a surgery to correct that condition. Things are not gonna, those eggs are not gonna be useful. So what we know about male aging is that, as we said, because of the different functionality and the presence of the stem cells in the testicles upon birth, their aging or fertility decline is not as exponentially, or it's not as abrupt as it is for us. When we talk about age, what we see with advancing male age is that there are some conditions that start to be more common in their offspring, such as conditions of the autism spectrum disorder, schizophrenia, and other things. So it's, but again, IVF in general and treatments that we have to treat infertility of couples is so much more successful and efficient when we treat even the most severe male factors, as opposed to, severe female factor, because even for men who have no sperm and they're, ejaculate, we could always retrieve, typically we could retrieve sperm from the testicles. And by using ICSI, we only need as many sperm cells as we get eggs retrieved. Compare that to a woman who has no eggs, or who's, at the zenith of her ovarian reserve, regardless of her age. She could be 23 or she could be 53. We don't have the ability to really overcome that issue that is as severe in the world of female fertility.
I've got one more question that we can probably have time for. Would you recommend egg freezing, or do you think pre-implantation genetic testing gives you enough information about the health of an egg?
Well, pre-implantation genetic testing it's a wonderful, technology that we have and that we've been using successfully for the past 26 years, actually, not just for chromosomal abnormalities, for also for known genetic mutations. The problem is not, first of all, you cannot test the egg, right? Because some of the mutations or the chromosomal abnormality that results in the embryo, a good proportion of them happens as the egg is maturing, because, before the egg matures and before your brain sends that LH surge, or before we give that trigger shot to mature the eggs in your ovaries, before we retrieve them, all the eggs contain 46 chromosomes. And when they go through the maturation, that really means that eggs need to lose half of the chromosomes. And what the mature egg is the egg that should only contain 23 chromosomes. One point at which with oocyte aging is one point of attrition, or one point of abnormality that we see, is that during that maturation, during continuation of the division called meiosis 1, even though egg should split into 23 chromosomes going into mature egg and 23 chromosomes going into this structure called polar body, whose function is to remove half of the chromosomes to prepare the egg to be fertilized by the sperm, so that a sperm, to make the room for the chromosomes that will be brought in by the sperm. So the new embryo again will have 46, 23 from the egg, 23 from the sperm. This split as a consequence of cellular aging and maybe not enough energy, probably comes down to mitochondria, just not enough energy in the cell, which is the hallmark of any cellular aging, including oocytes, is that this split is becoming less and less even. So instead of 23 and 23, it might split into 24 and 22. Some chromosomes stay stuck together. And so, yes, you can screen the eggs. The problem is, you cannot screen the eggs, you can screen the resulting embryos from those eggs. But the problem is the attrition is so big. And I would rather freeze the eggs when I'm younger, when I know that a good proportion of them will be giving rise to healthy embryos, than try to actually work through getting and creating embryos from eggs that are older, where a bigger proportion of them will be abnormal. You can always screen them. The problem is, will you have enough to screen? Will you actually get that healthy embryo? That's the problem, because there's a huge attrition even through IVF. You get 10 eggs retrieved, those 8 will be mature, 6 will fertilize and be made into embryos, and then maybe 2 to 5 will make it to the embryo that you can test. And the proportion of those embryos that you can test is variable in terms of chromosomal abnormality, and very heavily depending on age. So when you're in your 20s and early 30s, only 1 in 4 of those embryos will be chromosomally abnormal. Once you hit 35, it's 1 in 3. And then every year thereafter, it increases for about 5 to 10%. You reach 40, 2 out of 3 embryos will be abnormal.
Oh.
Sorry,
yeah.
I know it sucks. But that's how it is. And I think it's, the devil you know is better than the devil you don't know. So.
But I think what's encouraging is that there is actually a lot of technology to combat those challenges that our body's kind of throwing at us. And
yes,
there's
but I think this was and I get this question all the time. I think the question is great, because you think, well, why would I freeze eggs when I'm 27 if I can just do IVF and screen the embryos? The problem is that, you're 27, you get 10 eggs retrieved. You're now 38, you get 4 eggs retrieved. And maybe you make 1 or 2 embryos and both are abnormal. And then you have to do it again and again and again. And in fact, if you look at the CDC data, to which we all have to report our stats, the entire country, all of the IVF centers have to report the successfulness of their IVF and the outcomes really of the IVF cycles performed. On average, it takes 3 IVF cycles to a baby. And the median age of women undergoing IVF in our country is 35. It tends to be, for some, it tends to be a very long road.
Yeah. But I think it's amazing that there's doctors and physicians like you that are tackling that.
But ultimately, I tell everyone, sorry to interrupt you, Amy, but I think this is so important that it's probably the most important take-home point from this talk and from any encounter with me, because I'm a positive person. I'm very optimistic, and I've treated probably thousands of people so far. And today I discharged one of my patients who's been in my care for 3 years. It's been a very long journey for her, but they're 10 weeks pregnant and happy, and luckily we're here. Anyone can walk out of our office with a baby. And I always say, and Rena might know, if 2 guys walk out of my office with a baby, anyone can, right? Mm-hmm. Exactly. We're treating, same-sex couples, male, female, single women, single men. Anything could be substituted. Women without a uterus, women without eggs, men without sperm. And we have this field of medicine is rare in a sense that it does have an ability to treat 100% of its patients. It's just different modalities. You might need a modality that you did not want to have, but ultimately, anyone can walk out of here with a baby. So
I think that's interesting you said that, because there's very few things in our lives that we can say affects 100% of any population. And what you just said is absolutely true. And the tools are
isn't
there.
it? Don't
It's
you
just,
think? I mean,
I agree. In some way or another, I believe that any family can walk away with a baby for sure. But Dr. Lekovich, thank you so much for your time today. I hope everyone else found this to be as informative as I did. We are going to be sharing a recording of this with everyone after the event, so you could definitely refer to this going forward. I think the information you provided is just incredible. And then just as a reminder to all of our guests today, we are offering 15% off of your purchase until the end of the month. Just use the code PRESERVEYOURFERTILITY at oova.life. And Dr. Lekovich, we're going to be sending out an email later on thanking everyone for their time with the recording. Can we also include your contact information if anyone has any specific questions?
absolutely. Feel free. My Instagram, my email. It's a publicly available information. My email can be found online. It's on my card. So feel free to share it. I'll be happy to answer any additional questions, concerns. I mean, this is so little time. I could be talking about this for 7 days and still not give it all. So this was a very digest version, but there's much more to it. So any questions you might have, feel free to reach out. And thank you so much for organizing this. And I think this is amazing. And thanks for bringing the light into the dark world of female infertility and female fertility and aging and everything. I think the more we know about it, the better.
Exactly. That's exactly what our goal is. But thank you everybody for your time tonight. We'll see you in the next one.
Have a good night all. Bye.
Night.
Bye-bye. Good night.